Today we're navigating really the entire scope of clinical psychiatry, and this is a monumental field.
It really
It
is.
covers everything from the foundational rules of childhood behavior to the dizzying complexities of addiction, severe psychoses, and the enduring patterns that shape personality. It requires a lot of precision.
Precision is absolutely the key word. Our goal for you, the listener, is to move beyond just, cataloging these disorders.
Hmm.
We want to give you the critical clinical details, the specific temporal criteria, those exact numbers of days, weeks, and months, and the deep dive pharmacological specifics that truly define applied diagnosis and treatment in this discipline.
Exactly.
If you need a fast track to not just knowing about psychiatry, but understanding how it's practiced, this is it.
It is. We've synthesized a massive high-yield summary focusing on, well, categorization, clinical presentation, and those critical treatment strategies. Understanding the underlying biology and the specific nuance, the difference between 6 months and 1 month of symptoms, for instance, that's what transforms general curiosity into true insight.
We're going to slow the pace down a bit and really build this knowledge foundation step by step. Okay, let's unpack this, and we're starting right at the beginning. Childhood and adolescence. Let's start with attention deficit hyperactivity disorder, or ADHD. This is the disorder we probably most often encounter in school-age populations.
It is. ADHD is characterized by a persistent pattern of excessive inattention and/or excessive hyperactivity and impulsivity.
Okay.
Clinically, it typically starts presenting between the ages of 3 and 13, and our sources confirm it is statistically more common in males.
And the key here is that the behavior has to be, what, pervasive.
Pervasive is the perfect word. It has to cause impairment, and it has to be present in multiple settings. That's non-negotiable.
The sources break the symptoms into two distinct clusters. So for the inattention cluster, what are the common signs we should be looking for?
Well, you're looking for a pattern. It's carelessness with details, difficulty sustaining attention during work, or even during play. It's chronically struggling to follow instructions or finish tasks, general forgetfulness, and being easily distracted by extraneous stimuli. It's not just a refusal to focus, it's a real inability to maintain that focus effectively.
And the other cluster, the hyperactivity impulsivity component, this is more of the motor dimension, right?
Exactly. This manifests physically.
Yeah.
So constant fidgeting, leaving their seat when it's inappropriate, excessive running or climbing, or even just the subjective feeling of being internally restless.
Okay.
Also, difficulty engaging in quiet activities, talking excessively, and impulsive behaviors like interrupting others or, blurting out answers before a question is even finished.
Now, here is where the diagnostic line is drawn. And this is so specific. This is what separates, an active child from a clinical disorder. What are the critical, non-negotiable requirements?
Okay, so first, the symptoms must be present for a period of at least 6 months. That is the first anchor point.
6 months. Got it.
Second, they must cause genuine impairment in functioning academically, socially, you name it. And third, they absolutely must occur in 2 or more separate settings. Home and school are the classic pair.
So let me just clarify. If a child only exhibits all these traits when they are at their grandmother's house, but they function perfectly in school and at their own home, that doesn't count.
Nope, it doesn't count because that suggests a setting-specific behavioral response, not a pervasive neurodevelopmental disorder. The disorder has to be, portable.
That's a great way to put it.
And another thing, the number of required symptoms actually changes with age. If you are up to age 17, you need at least 6 symptoms from either or both categories. But if you are 17 or older, that threshold drops slightly to at least 5 symptoms. That's a detail a lot of people miss when they're looking at the criteria.
Before initiating treatment, it's vital to check if a substance or a medical issue is actually masquerading as ADHD. What are the key items on that differential list?
We have to look for specific organic reasons. Things like potential substance abuse in an adolescent, lead toxicity, thyroid disorders, or often overlooked issues like hearing or visual impairments.
Things that would make it hard to pay attention for anyone.
Exactly. Or sleep disorders, or even absence seizures. Treating an underlying medical issue, not just the behavior, is the priority here.
Turning to treatment, the approach is entirely dependent on the child's age, which is a critical age-dependent decision point.
Precisely. For the youngest children, ages, say, 4 to 5 years old, the best initial treatment is solely behavior therapy. We reserve medication for those cases where behavior therapy just fails to provide adequate improvement.
Okay, so that's for the little ones.
But once a child is 6 years or older, the first-line treatment shifts to a combination approach. Pharmacologic therapy plus behavior therapy.
And the pharmacology hinges on CNS stimulants.
Yes. Central nervous system stimulants like methylphenidate or amphetamine salts are the mainstay because paradoxically, they improve focus and reduce impulsivity.
Right.
They are very effective, but we must note a key contraindication. The use of stimulants is absolutely avoided for individuals with illicit substance abuse or those at high risk for addiction. This includes situations where the home environment might introduce risk.
And let's detail those side effects because they are often the reason for switching medications.
Of course. The most common and notable adverse effects are weight loss due to appetite reduction, insomnia, anxiety, irritability, and headache.
And what about growth? I know that's a big concern for parents.
It is. There can be a temporary and often minor decrease in growth velocity, which requires monitoring. To mitigate the appetite reduction and subsequent weight loss, we strongly recommend that the stimulant dose be timed to be administered after the patient has eaten meals.
That's a great clinical pearl. So what if a patient struggles with the stimulant profile? What are the alternatives?
Then we turn to non-stimulants. Atomoxetine, which works as a norepinephrine reuptake inhibitor, is often preferred for those who suffer negative side effects from stimulants.
And second line.
Second-line alternatives include the alpha-2 agonists, like guanfacine or clonidine, or occasionally bupropion or tricyclic antidepressants, TCAs.
Okay.
And we have to clarify a common misconception. Diet, things like sugar or food additives, is explicitly not considered an etiologic factor for ADHD.
That's a huge one. Good to clarify. All right, moving on to autism spectrum disorder, or ASD.
ASD is a pervasive neurodevelopmental disorder defined by impairments in two major non-negotiable domains. First, deficits in social interaction and communication.
And the second.
And second, repetitive or restricted behaviors, interests, or activities. Like ADHD, it is also more common in males.
The social impairment aspect is, well, it's heartbreaking to review.
It truly is. We see reduced interest in socialization, a striking lack of empathy, an inability to form age-appropriate relationships, poor eye contact, and significant delays or impairment in language development.
And in the restricted behavior domain.
There we find repetitive patterns like hand flapping or spinning, a rigid, strict adherence to non-functional routines, and an abnormal, often extreme response to sensory input.
How so?
This might be indifference to pain or a hypersensitivity to specific sounds or temperatures.
The diagnosis is typically made early, and the severity is dynamic, right? It's not one single thing.
Not at all. Symptoms must impair academic or social function and must be present in the early developmental period, generally determined by age 3. And severity is entirely dictated by the required level of support for that individual to function.
And you have to rule out other things first.
You do. Diagnosis necessitates excluding intellectual disability or global developmental delay, and importantly, ruling out any hearing impairment using audiometry, as hearing loss can mimic communication deficits.
You also mentioned a significant associated condition, Fragile X syndrome.
Yes, Fragile X syndrome is crucial. It's the leading inherited cause of intellectual disability. It has a specific physical presentation, macroorchidism, a long face, and a prominent jaw. It's always part of the differential screen when IDD or ASD is suspected.
What does the treatment plan look like for ASD? It sounds like it would need to be very comprehensive.
It is. Treatment is highly intensive and multidisciplinary. It involves specialized education and comprehensive behavior management, often applied behavior analysis, or ABA focused on building critical skills.
And medications.
Symptom-targeted medications are used for comorbidities. So stimulants for co-occurring ADHD, neuroleptics for severe aggression or mood instability, and sometimes SSRIs for stereotypic behaviors or anxiety.
Next, we have a cluster of related but distinct conditions known as disruptive behavioral disorders. We have oppositional defiant disorder, ODD, conduct disorder, CD, and disruptive mood dysregulation disorder, DMDD.
Right, ODD is the starting point. It is a persistent pattern of negative, defiant, disobedient, and hostile behavior towards authority figures, and it has to last for at least 6 months.
So things like losing their temper, arguing.
Exactly. Losing their temper, arguing, actively defying requests are common. It's significant because ODD can often progress into the more severe conduct disorder.
How does conduct disorder escalate beyond ODD? It sounds more serious.
It is much more serious. Conduct disorder is a repetitive and persistent pattern of violating the basic rights of others or age-appropriate societal norms and rules, requiring a minimum duration of 1 year.
And the behaviors are much more severe.
Far more aggressive and damaging than ODD. We're talking about aggression, including violence, robbery, or animal cruelty, destruction of property, deceitfulness, and serious rule violations such as truancy or running away.
And there's an age cutoff for this one, right?
Yes. This diagnosis is reserved for those under 18. After that, this pervasive pattern of behavior is relabeled as antisocial personality disorder.
And the third one, DMDD, seems to sit between conduct and mood issues.
It does. DMDD is characterized by severe, recurrent, verbal or physical aggression outbursts that are grossly out of proportion to the situation.
What's the key differentiator?
The key differentiator is that the child maintains a chronically irritable or angry mood between the outbursts. Symptoms must occur for at least 1 year, and diagnosis must be made specifically between ages 6 and 18.
And this is important because it can lead to other things later on.
It is. This disorder is significant because it is a pathway that may progress to depression in adulthood.
For all three of these disruptive behavioral disorders, the first-line treatment is unified.
That's right. Psychotherapy is the first-line treatment for oppositional defiant disorder, conduct disorder, and disruptive mood dysregulation disorder.
Let's cover intellectual developmental disorder, or IDD.
So IDD is defined by deficits in cognitive, social, and practical functioning, with the onset occurring before age 18.
And the cause.
The etiology is broad, but the most common identifiable genetic cause is Down syndrome. We also link it to male sex, congenital infections, maternal toxins like alcohol and illicit substances, and inborn errors of metabolism.
You mentioned adaptive functioning deficits. That requires a definition. What does that mean in practical terms?
Yes, ADL's activities of daily living are the standard benchmark. This means struggling with hygiene, social functioning, and basic self-care.
And severity isn't just an IQ number.
Right. Severity is determined not by IQ scores alone, but by the required level of support. It ranges from mild, where the individual is largely independent in ADLs, to profound, where they require assistance for all ADLs.
Primary prevention efforts seem critical here.
They are. They focus on education and optimal prenatal screening. Treatment involves a massive support network: family counseling, speech and language therapy, occupational and physical therapy, and remedial educational assistance targeted at specific deficits.
Finally, in our early life section, Tourette syndrome and separation anxiety disorder. Let's start with Tourette's and those involuntary tics.
Tourette syndrome requires the presence of both multiple motor tics and one or more vocal tics. It's more common in males and often co-occurs with ADHD and OCD. Stress and fatigue reliably worsen the symptoms.
What is the specific timeline required for diagnosis?
The Tourette's must have been present for more than 1 year, recurring many times per day or nearly every day.
And what do these tics look like?
Motor tics can be blinking or grimacing. Vocal tics can be grunting, throat clearing, echolalia, which is repeating others, or coprolalia, which is the involuntary swearing.
And you have to distinguish this from chronic tic disorder.
Exactly. With chronic tic disorder, the patient has motor or vocal tics, but not both, lasting over a year.
What's the optimal strategy for managing these tics?
Behavior therapy, specifically habit reversal, is considered the best initial treatment. It's about teaching awareness and a competing response.
And if that's not enough...
When pharmacologic management is needed, we look at dopamine-depleting agents. For instance, tetrabenazine, which is a VMAT2 inhibitor. Basically, it stops dopamine from being packaged up, or classic dopamine-blocking antipsychotics like fluphenazine or risperidone.
I see alpha-2 agonists listed here as well.
Yes, agents like clonidine or guanfacine are also used. They tend to have a more favorable side effect profile, though they're often less potent at TEDx reduction.
And separation anxiety disorder.
This is an excessive fear of separation from an attachment figure or home, which must persist for at least 4 weeks in children or 6 months in adults. The peak presentation is around 18 months, and it's often triggered by a stressful event.
What are the symptoms? It's more than just being sad when a parent leaves.
Oh, much more. It's extreme distress upon separation, excessive worry about harm to the attachment figure, nightmares about separation, and physical symptoms like stomach aches that occur specifically when separation is imminent. Treatment involves CBT, family therapy, and often SSRIs as an adjunct for the anxiety.
That wraps up our dense look at the early life foundations. We've established how precise these diagnostic criteria are, hinging on duration, 4 weeks, 6 months, 1 year, and context.
Indeed. Now, we shift dramatically. We're moving away from developmental foundations and into the space where the brain fundamentally breaks the rules of reality itself, psychosis and dissociation.
When we talk about thought process disorders, schizophrenia is the standard. It's this mix of positive symptoms, the added experiences like hallucinations, and negative symptoms, the subtraction of normal function, like withdrawal.
Schizophrenia affects about 1% of the population. Onset is earlier in males, typically 18 to 25 years. It's a tragedy for patients and families, and the suicide risk is high, about 10%.
And what do we know about the cause?
Etiologically, we see dopamine dysregulation, specifically frontal hypoactivity and limbic hyperactivity, and clear structural brain abnormalities, notably enlarged ventricles and decreased cortical volume.
Let's clarify those symptom clusters before we get to the criteria, the positive and negative symptoms.
So positive symptoms are the acute signs of psychosis. Hallucinations, which are most often auditory, delusions, which are fixed, false beliefs, disorganized speech, and disorganized or catatonic behavior.
And the negative symptoms.
Negative symptoms are the deficits: flat affect, social withdrawal, anhedonia, which is the inability to feel pleasure, apathy, avolition, which is decreased motivation, and minimal speech, or alogia.
There's a mnemonic for that, right?
Yes. A simple way to remember the deficits is the 5 A's of schizophrenia: affect, alogia, avolition, anhedonia, and asociality.
Now, the strict diagnostic criteria for schizophrenia, this is the ultimate anchor point for this section.
The patient must exhibit at least 2 symptoms that cause occupational or social dysfunction, and these must be present for a minimum of 6 months.
6 months.
And furthermore, at least one of those 2 symptoms must be a hallucination, a delusion, or disorganized speech. If I had to bet on one thing people mix up, it's that strict temporal rule that defines the diagnosis.
So how do we use that duration criterion to draw the line between schizophrenia and the disorders that look just like it?
This is the highest yield concept here.
Oh.
The temporal differential diagnosis of psychotic disorders. We use duration like a ruler.
Okay, lay it out for us.
The shortest lived is brief psychotic disorder. This lasts from 1 day to 1 month.
Okay, 1 day to 1 month.
The next step up is schizophreniform disorder. It presents identically to schizophrenia, but lasts only between 1 and 6 months. This often suggests a better prognosis.
And if it goes past 6 months?
If symptoms persist beyond 6 months, it becomes schizophrenia.
What about schizoaffective disorder, which blends psychosis and mood? That one always seems tricky.
It is tricky. It requires that the psychotic symptoms, the schizophrenia criteria, must last for at least 2 weeks without a concurrent major mood episode.
So 2 weeks of just psychosis.
Exactly. PLUS, a major mood disorder episode, either depression or mania, must be present for the majority of the total illness duration. The key is those 2 weeks of pure psychosis, independent of the mood swing.
And how do we place delusional disorder on this spectrum?
Delusional disorder involves persistent non-bizarre delusions. So, plausible, fixed false beliefs, like being followed or being cheated on, with otherwise intact, non-disorganized thought or behavior. It requires a minimum duration of 1 month.
Long-term management of these conditions means antipsychotic medication. Let's get into the deep details of the pharmacology and the highly critical adverse effects.
Right. Treatment is lifelong, combining medication with psychotherapy, social skills training, and vocational rehab. The primary targets of these medications are the dopamine receptors.
Starting with the typical or first-generation antipsychotics, which are D2 antagonists.
We categorize them by potency. High-potency agents like haloperidol and fluphenazine are used for acute agitation, mania, and psychosis. They are effective but have a high propensity for extrapyramidal symptoms, or EPS.
And the low-potency ones.
Low-potency agents like thiordazine and chlorpromazine are more sedating. They have a greater risk of orthostatic hypotension. And specifically, thiordazine carries a particularly high risk of QTc prolongation and irreversible retinal pigmentation.
Aside from the sedating effects, the most severe complication of these first-gen drugs is EPS.
Absolutely. Plus, they cause anticholinergic effects, dry mouth, urinary retention, and that QTc prolongation.
The atypical or second-generation antipsychotics are first line today, partly because they interact differently.
They do. They primarily work as 5-HT2A antagonists while also blocking D2 receptors, though less fiercely. This group includes risperidone, quetiapine, olanzapine, ziprasidone, and clozapine. They are preferred because they have a much lower incidence of EPS and anticholinergic effect.
However, they trade the motor side effects for a different and equally severe set of risks, metabolic syndrome.
Exactly. Due to their interaction with serotonin receptors, there is a significantly high risk of metabolic syndrome. That means high weight gain, dyslipidemia, and rapid progression toward type 2 diabetes mellitus. Clinicians must monitor metabolic panels regularly.
2 drugs in this category require specific mandatory monitoring.
Yes. Clozapine is reserved for treatment-resistant cases because it carries the risk of a granulocytosis, a severe drop in white blood cells. This mandates weekly CBC monitoring during the initial 6 months of treatment.
And the other?
Separately, risperidone and paliperidone carry a specific risk of hyperprolactinemia, which can cause amenorrhea, galactorrhea, and sexual dysfunction.
Now, let's drill down into extrapyramidal symptoms, EPS. We need to distinguish 4 unique conditions based on their timing and presentation. Think of EPS as a spectrum of dopamine blockade issues.
This is vital information for you to know.
First, acute dystonia.
This is the immediate emergency happening within hours of starting the drug. It presents as prolonged, painful muscle contractions, think torticollis, a twisted neck, or oculogeric crisis, a fixed upward gaze.
And the treatment is immediate.
Immediate. Anticholinergics like benztropine or diphenhydramine.
Second, akathisia.
This is one of the more common side effects, starting after weeks. It's subjective and objective restlessness. The patient feels distressed and compelled to constantly move.
How do you treat that?
Treatment involves reducing the neuroleptic dose, using beta blockers like propranolol or benzodiazepines.
Third, dyskinesia or pseudo-Parkinsonism.
This also occurs after weeks. It mimics Parkinson's disease. Tremor, shuffling gait, rigidity. Treatment is reducing or discontinuing the neuroleptic or treating with anticholinergics or amantadine.
And fourth, tardive dyskinesia, TD. This is the long-term, possibly irreversible damage that shows up months later.
TD has a much later onset, typically after months of chronic dopamine blockade. It involves stereotypic, involuntary, painless oral or facial movements. The danger is that it is often irreversible in 50% of cases.
And how do you treat TD?
Treatment involves discontinuing the offending neuroleptic, possibly switching to a lower-risk atypical, and treating with VMAT2 inhibitors like valbenazine or deutetrabenazine to deplete presynaptic dopamine.
Finally, the rare but life-threatening neuroleptic malignant syndrome, or NMS.
NMS can occur at any time and requires immediate emergency treatment. The presentation is classically fever, severe muscle rigidity, profound autonomic instability, and lab findings showing elevated creatinine kinase and white blood cells.
And treatment.
Immediate discontinuation of the medication, intensive supportive care in the ICU, and administering specific muscle relaxants, dantrolene or bromocriptine.
Let's shift to dissociative disorders, where there is a profound disruption of memory, identity, and perception.
These conditions are not caused by substance use. The most dramatic is dissociative identity disorder, or D-DIME.
Formerly known as multiple personality disorder.
Yes. It is defined by the presence of 2 or more distinct personalities or behavior patterns that take control at different times. It is strongly associated with a history of severe childhood trauma and frequently co-occurs with PTSD and borderline personality disorder.
And the distinction between depersonalization and derealization.
So depersonalization is the detachment from one's own self-feeling, like an outside observer of your own body or thoughts.
Okay.
Derealization is the feeling that one's surroundings are unfamiliar or unreal. The disorder involves recurrent experiences of one or both states.
Dissociative amnesia is the inability to recall important personal information, usually after a trauma.
Correct, but procedural memory, how to drive a car or play an instrument, is preserved. The dissociative fugue subtype involves unexpected travel during this state. For all these disorders, the best initial treatment is psychotherapy, with SSRIs added only for comorbid depression or anxiety.
That concludes the realm of psychosis. We've established the strict chronological rules of psychotic disorders. Now, let's move to where the internal conflict is constant, defined by relentless, excessive worry, the anxiety spectrum. Generalized anxiety disorder, or GAD, is characterized by persistent, uncontrollable, excessive worry about multiple topics.
It's common in females and usually starts in the early 20s. And the diagnosis, once again, it hinges on a strict temporal requirement. The excessive anxiety and worry must occur on more days than not for a period of at least 6 months.
Let me just anchor on that 6-month rule.
Yeah.
That really highlights the difference between temporary stress and a diagnosable pervasive condition.
It's the hallmark of GAD. And to formalize the diagnosis, we require at least 3 somatic symptoms from the WRRI mnemonic.
Can you break that down for us?
Of course. It's worry, restlessness, reduced concentration, irritability, muscle tension, and sleep disturbance.
What's the optimal treatment pathway for GAD?
The best initial approach is combining psychotherapy, specifically CBT, with a pharmacological agent. Usually SSRIs like fluoxetine or SNRIs like venlafaxine.
Are there alternatives?
Yes, alternatives include buspirone, which is a 5-HT partial agonist, or for very short-term use, benzodiazepines. Crucially, SSRIs must absolutely never be used in combination with monoamine oxidase inhibitors or MAOIs due to the risk of serotonin syndrome.
Next, panic disorder. This is defined by recurrent, unexpected episodes of intense fear.
A panic attack is a discrete period of intense fear that peaks within 10 minutes and includes at least 4 symptoms: palpitations, chest pain, shortness of breath, dizziness, or the crushing fear of dying.
So that's the attack itself. What makes it a disorder?
Panic disorder is diagnosed when the patient experiences recurrent, unexpected attacks, followed by at least 1 month of persistent worry about having another attack. It is highly associated with agoraphobia and carries an increased suicide risk.
How do we treat the acute attack versus the long-term illness?
Acute attacks are managed with benzodiazepines, but we must be extremely cautious due to the risk of dependence. They are best reserved for short-term acute relief.
And for long-term control?
For long-term control, the first line is the combination of SSRIs, sertraline is a common choice, and CBT. The combination approach yields the highest response rates.
Moving to phobias.
Phobias are excessive, unreasonable fears stimulated by a specific object or situation lasting at least 6 months. Social anxiety disorder is the excessive fear of criticism or humiliation in social interactions.
And the treatment for performance-only anxiety is unique. I found this really interesting.
It is. For generalized social anxiety disorder, CBT and SSRIs are first line. But for the performance-only subtype, say fear of public speaking, the preferred pharmacologic treatment is beta blockers, such as propranolol,
Why is that?
because it addresses the somatic symptoms like the tremor and the racing heart without clouding your cognition. For specific phobias, the first-line treatment is simple and non-pharmacologic, CBT using incremental exposure. We call it exposure therapy.
Let's discuss obsessive-compulsive disorder, OCD, and its related conditions.
OCD is characterized by obsessions, compulsions, or both, that are time-consuming, meaning they take up more than 1 hour daily and cause distress.
But what's the difference between an obsession and a compulsion?
Obsessions are persistent, unwanted, intrusive thoughts like contamination fears. Compulsions are the mental acts or behaviors, the rituals, performed to neutralize the anxiety, like excessive hand-washing.
The brain pathology is centered around specific areas, correct?
Yes, brain imaging shows abnormalities in the orbital frontal cortex, the basal ganglia, and the cingulum, which control inhibitory control and behavioral feedback.
What's the gold standard treatment for OCD?
The best initial treatment is SSRIs, often at a high dose, or clomipramine, which is a powerful TCA that is highly effective for OCD. Non-pharmacologically, CBT using exposure and ritual prevention, ERP, is the standard.
We have to highlight the difference between OCD and obsessive-compulsive personality disorder, OCPD. This is often confused.
This is a major clinical distinction. OCD patients recognize their obsessions and compulsions as irrational and unwanted. They are ego-dystonic. They're distressed by the disorder.
And OCPD patients.
OCPD patients, however, are excessively preoccupied with perfection, order, and control, but they are egosyntonic. They believe their rigid rules and behaviors are necessary and correct, and their problems are external. OCPD is often the underlying personality for those who may eventually develop OCD.
Let's briefly touch on the other related disorders.
We have body dysmorphic disorder, BDD, a preoccupation with an imagined or slight defect in appearance, which is treated with SSRIs and CBT.
Okay.
Hoarding disorder, where the difficulty discarding possessions leads to unsafe clutter. And impulse control issues like excoriation, skin picking, trichotillomania, hair pulling, and kleptomania, which is the impulse to steal without the motive of financial gain.
Finally, trauma and stressor-related disorders, PTSD and acute stress disorder.
PTSD requires exposure to an extreme, life-threatening event. Key risk factors include sexual assault and war in males, and childhood abuse and sexual assault in females. Diagnosis required symptoms to last for at least 1 month.
The diagnostic clusters are comprehensive. Can you walk us through them?
They are: 1. Intrusive symptoms like flashbacks and nightmares. 2. Avoidance of stimuli related to the trauma. 3. Negative alterations in mood and cognition like detachment or anhedonia. And 4. Arousal and reactivity like hypervigilance or an exaggerated startle response.
How does acute stress disorder, ASD, differ?
ASD has similar symptoms, but the timeline is the differentiator. The presentation must be between 3 days and 1 month after the trauma. If symptoms persist beyond 1 month, the diagnosis changes to PTSD.
And treatment?
For both, the best initial treatment involves trauma-focused CBT or eye movement desensitization and reprocessing, EMDR, which is a specific structured technique used to reduce distress associated with traumatic memories.
And pharmacologically?
Pharmacologically, SSRIs or SNRIs are first line. A specialized approach is the use of brazosine, an alpha blocker, used specifically to treat PTSD-related nightmares.
We've established the duration rules for anxiety and trauma. Now we move to the brain's effect regulators, mood and cognition. Major depressive disorder, MDD, is defined by one or more major depressive episodes. It typically starts in the mid-20s and is significantly more prevalent in females.
The diagnosis requires either a depressed mood or anhedonia, the loss of interest or pleasure, and at least 5 symptoms from the clinical criteria, persisting for a minimum of 2 weeks.
So 2 weeks is the magic number. 2 days of feeling down isn't a clinical diagnosis. It's the persistence over 14 days that transforms normal sadness into a pathology requiring intervention.
Exactly. The persistence is key.
For MDD, I recall there's a highly useful way to remember those required symptoms. Can you walk us through the mnemonic you outlined in your notes?
Absolutely. We use the SIG-E-CAPIAS mnemonic to check for the 9 symptoms. S is for sleep, increase or decrease.
Okay, SIG.
I is for interest, loss of anhedonia. G is for guilt, inappropriate or excessive. E is for energy, decreased fatigue. C is for concentration, decreased. A is for appetite or weight, increase or decrease. P is for psychomotor agitation or retardation. And S is for suicidal ideation. 5 of these, for 2 weeks, signals MDD.
We must also recognize the 3 stages of postpartum mood disturbance. This seems really important.
It is. Postpartum blues sets in within 2 weeks and is self-limiting. Postpartum depression occurs 1 to 3 months postpartum and requires standard antidepressant treatment.
And the most severe?
The most severe, postpartum psychosis, occurs 2 to 3 weeks postpartum and involves delusions and disorganized behavior. It carries a significant risk of harm to the baby, requiring emergent intervention.
What's the treatment protocol for MDD?
First-line treatment combines SSRIs with therapy. We must allow 4 to 6 months for full remission. If a partial response occurs, we can augment with a second agent like bupropion or an atypical antipsychotic or switch classes entirely.
And for severe treatment-refractory depression?
Electroconvulsive therapy, ECT, is a safe, highly effective option for severe or refractory depression, or for high-risk patients like those who are actively suicidal or catatonic who need rapid improvement. It requires 6 to 12 treatments.
Let's break down the antidepressant classes, focusing intensely on side effects and risk, starting with SSRIs.
SSRIs are first line. Side effects are GI distress, insomnia, headache, and commonly sexual dysfunction. The key danger, which we keep repeating because it's life-threatening, is serotonin syndrome if they're combined with MAOIs.
What about the atypical antidepressants?
Bupropion is unique. It's also used for smoking cessation, but it lowers the seizure threshold. It is strictly contraindicated in patients with eating disorders or seizure disorders. Mirtazapine is often used when weight gain and sedation are actually beneficial.
And the older, riskier classes, SNRIs, TCAs, and MAOIs.
SNRIs like venlafaxine and duloxetine treat depression, anxiety, and neuropathic pain, but their notable side effect is dose-related hypertension.
And TCAs.
TCAs, like clomipramine and imipramine, have significant anticholinergic effects and orthostatic hypotension. But the highest risk is cardiotoxicity QTc prolongation, making them fatal in overdose.
Finally, MAOIs.
MAOIs, like phenelzine, are reserved for atypical depression.
Right.
Their severe risk is the hypertensive crisis if they're taken with high tyramine foods, like aged cheese or wine.
Moving to bipolar and related disorders characterized by alternating episodes of mania or hypomania plus depression.
Onset is typically age 20. We categorize them based on the severity and duration of the elevated mood episodes, often using the DIGFAST mnemonic.
Can you break that one down?
Sure. Distractibility, insomnia, grandiosity, flight of ideas, activity, sexual indiscretion, and talkativeness.
Mania versus hypomania. Where do we draw the line? This is a critical distinction.
The line is drawn by severity and consequence. Mania is severe, lasts for at least 1 week, or any duration if hospitalization is required, causes significant impairment, and may involve psychotic features.
And hypomania.
Hypomania is less severe, lasts for at least 4 days, does not require hospitalization or cause significant impairment, and has no psychotic features.
And the subtypes. Bipolar 1 versus bipolar 2.
Bipolar I requires at least 1 full manic episode. Bipolar 2 requires at least 1 hypomanic episode plus a major depressive episode.
And cyclothymic disorder.
That involves alternating hypomanic and depressive symptoms that don't meet full criteria, lasting for at least 2 years.
Treatment for acute mania is urgent.
Acute mania is a psychiatric emergency. For mild mania, atypical antipsychotics like olanzapine are used. For severe mania, we combine a mood stabilizer lithium, or valproate, plus an antipsychotic.
Again, long term.
Maintenance requires lifelong mood stabilizer treatment, with lithium being preferred. For bipolar depression, we start the mood stabilizer first to prevent inducing a manic switch.
Let's detail the mood stabilizers, focusing on their narrow therapeutic windows, starting with lithium.
Lithium is first line, but it has a very narrow therapeutic window, requiring regular blood level monitoring. Common side effects include tremor and weight gain.
And the severe risks.
The severe risks are hypothyroidism, nephrogenic diabetes insipidus, and in pregnancy, keratogenicity, specifically associated with Epstein anomaly in the first trimester.
And the anticonvulsants used as stabilizers.
Lamotrigine is effective, but requires monitoring for a rash that can progress to Stevens-Johnson syndrome. Valproic acid is also effective, but carries risks of hepatotoxicity, pancreatitis, and teratogenicity, specifically neural tube defects. Carbamazepine carries risks of skin rash and leukopenia.
We transition now to neurocognitive disorders, dementia and delirium. The ability to differentiate between these two is absolutely essential in clinical practice.
Dementia, or major neurocognitive disorder, is a gradual, progressive cognitive decline, and it's largely irreversible. The most common causes are Alzheimer's, about 65%, and vascular dementia, about 20%.
And the diagnosis requires ruling things out first.
Yes, ruling out the pseudodementias like depression or treatable causes such as B12 deficiency and thyroid dysfunction.
And delirium is fundamentally different. It is acute and reversible.
Delirium is an acute disturbance of consciousness and cognition, often developing over hours to days. It's common in critical care or postoperative settings. The critical fact is that delirium is always reversible if the underlying cause is treated.
There's a mnemonic for the causes, but can we focus on the most common or easily missed ones that need rapid intervention?
Of course. The most critical causes to check immediately are infection, like a UTI in the elderly, withdrawal, especially from alcohol or benzodiazepines, acute metabolic issues, hypoxia, and toxins or drugs. These are often life-threatening and require swift action.
Let's compare the key features of delirium versus dementia.
The differences are stark. In delirium, attention is impaired and fluctuating. The onset is acute, and the course fluctuates, often worsening at night, which we call sundowning.
Right.
Hallucinations are common, often visual or tactile, and the prognosis is reversible. In dementia, the patient is usually alert. The onset is gradual. The course is progressive deterioration. Hallucinations are rare until advanced stages, and the condition is largely irreversible.
And treatment for both.
For delirium, treat the underlying cause first. Non-pharmacologic interventions, a consistent environment, mobilization are priority. Low-dose antipsychotics can manage agitation, but benzodiazepines should be avoided as they often worsen the confusion.
And for dementia?
For dementia, cholinesterase inhibitors like donepezil and NMDA antagonists like memantine can slow the decline. Here, too, benzodiazepines should be avoided due to the risk of disinhibition and increased mortality.
We now move to the enduring patterns of behavior that shape personality and the profound biological effects of substance use. Personality disorders, or PDs, are defined by inflexible, pervasive patterns of inner experience and behavior that cause social dysfunction. The key characteristic is that the patient believes the problems are external.
They're egocentric. They see their personality as normal and necessary. Treatment is primarily psychotherapy, with pharmacotherapy reserved for comorbidities like anxiety or mood swings. We divide them into 3 clusters.
Cluster A, the weird audicentric cluster.
Paranoid PD involves distrust and suspicion, often using projection, attributing their unacceptable internal impulses to others as a defense mechanism. Schizoid PD describes the detached loners with restricted emotion. And schizotypal PD involves odd behavior, magical thinking, and ideas of reference.
Cluster B, the wild, dramatic, emotional, erratic cluster.
Borderline PD is characterized by unstable mood, relationships, self-image emptiness, and a history of self-harm. Their primary defense mechanism is splitting viewing people or situations as entirely good or entirely bad.
Okay.
Histrionic PD is defined by excessive emotion, attention-seeking, and inappropriate sexual behavior. Narcissistic PD involves grandiosity, entitlement, and a marked lack of empathy.
It almost sounds like the cluster B types are built for high-stakes reality TV.
They often thrive on drama and external validation. And for antisocial PD, the diagnosis can only be made if the patient is 18 years or older and has evidence of conduct disorder before age 15. They violate norms and laws and lack remorse.
Cluster C, the worried and wimpy, anxious, fearful cluster.
Avoidant PD patients desire friends, but are paralyzed by the fear of social interaction and rejection. Dependent PD patients are submissive and clingy, feeling helpless and struggling to make decisions. And lastly, obsessive-compulsive PD, OCPD, defined by preoccupation with perfection and control, which we noted is distinct from OCD because the patient views the behavior as correct, egosyntonic.
Let's reinforce the spectrum of defense mechanisms.
The immature mechanisms often express unacceptable thoughts through actions: denial, acting out, projection, attributing blame, and splitting.
And this is where it gets really interesting for understanding people.
Absolutely. If you observe someone using splitting in a highly charged argument, how does that recognition alter your analysis of the conflict itself? You're seeing past the content of the argument and into the structure of their defense. The mature mechanisms are healthy coping strategies: sublimation, channeling urges into socially acceptable activities, altruism, suppression, and humor.
Now, for one of the most critical sections, substance use disorders, SUDs, and withdrawal. The signs of intoxication and withdrawal are life and death knowledge.
Diagnosis requires 2 or more of 11 criteria within a 1-year period, covering impaired control, social impairment, risky use, and pharmacologic signs, like tolerance or withdrawal. But withdrawal is not required for diagnosis.
Starting with the depressants, alcohol.
Alcohol intoxication causes disinhibition, slurred speech, and ataxia. Alcohol withdrawal is life-threatening, and the timeline is crucial.
Break down that timeline for us.
At 6 to 24 hours, you get anxiety and tremor. At 12 to 48 hours, you can have seizures. And at 48 to 96 hours, 2 to 7 days, that's the window for delirium tremens, DTs, a life-threatening state involving fever, agitation, and profound autonomic instability.
And the treatment has to be aggressive.
Very aggressive. Benzodiazepines plus thiamine, folate, and multivitamins to prevent Wernicke encephalopathy.
Next, opioids.
Opioid intoxication presents with euphoria, lethargy, pupillary constriction, which we call miosis, and most dangerously, significant respiratory depression. Acute reversal uses naloxone.
And withdrawal.
Opioid withdrawal is intensely uncomfortable but not life-threatening. You see anxiety, flu-like symptoms, diarrhea, myalgias, and pupillary dilation, or mydriasis. Long-term treatment often involves methadone or buprenorphine.
Now for the stimulants, amphetamines, and cocaine.
Stimulant intoxication involves psychomotor agitation, paranoia, pupillary dilation, mydriasis, and tachycardia. Cocaine is unique because of its ability to cause chest pain and myocardial ischemia. Withdrawal is a crash involving lethargy, depression, and increased appetite. Treatment is supportive.
And the hallucinogens, focusing on the most dangerous, PCP.
PCP, phencyclidine. Intoxication is highly dangerous. It causes assaultive, combative behavior, severe psychosis, violence, nystagmus, and hypertension. These patients are at severe risk of trauma.
And treatment.
Treatment involves benzodiazepines, physical restraints, and sometimes haloperidol. LSD causes visual hallucinations and synesthesia, but no significant withdrawal. And MDMA, ecstasy, carries risks of hyperthermia, hyponatremia, and serotonin syndrome.
Our penultimate topic, somatic symptom and related disorders. Physical complaints driven by psychological distress.
Somatic symptom disorder involves excessive thoughts, anxiety, and behaviors driven by the presence of somatic symptoms, like pain or fatigue, that are distressing, even without a clear medical explanation. The key is high healthcare utilization.
So how do you treat that?
Treatment involves regular, low-key appointments with one primary care provider, avoiding unnecessary diagnostics, and psychotherapy focused on stress reduction.
Illness anxiety disorder, the new hypochondria.
This is a preoccupation with acquiring a serious medical illness for at least 6 months, despite minimal symptoms and medical reassurance. The anxiety about health is profound. Treatment is best managed with CBT as the first line.
And conversion disorder, where the symptoms defy medical explanation.
This involves motor or sensory symptoms, paralysis, blindness, that are incompatible with medical processes, often following intense stress. A key diagnostic feature is labile indifference. The patient appears strangely indifferent to their profound, life-altering symptoms.
Finally, the distinction between factitious disorders and malingering.
Factitious disorder, or Munchausen syndrome, involves the falsification of symptoms solely to assume the sick role. We call that primary gain. The motivation is internal and unconscious.
And malingering.
Malingering, however, involves intentionally feigning symptoms for a conscious secondary gain like financial benefits or avoiding legal issues. The intent separates them.
We now move to our final essential section, covering safety, sleep, and sexual health. Let's start with primary insomnia.
Insomnia is difficulty initiating or maintaining sleep, occurring at least 3 nights per week for at least 1 month.
What's the non-pharmacologic approach? That seems to be first line for a lot of these things.
It is. The best initial treatment is rigorous sleep hygiene measures. A consistent schedule, limiting caffeine, using the bed only for sleep and sex. The next best treatment is CBT for insomnia, or CBTI. Pharmacologic agents like zolpidem are reserved for short-term use.
Narcolepsy and its unique triad of symptoms.
Now, narcolepsy is characterized by excessive daytime somnolence and a decreased REM sleep latency. The classic symptoms are the triad. Cataplexy, which is a sudden muscle tone loss often triggered by emotion.
Right.
Hypnagogic hallucinations, which happen while falling asleep, and hypnopompic hallucinations, which happen while waking up. Treatment involves scheduled naps and stimulants like modafinil.
And sleep apnea.
Obstructive sleep apnea, or OSA, is strongly associated with obesity and male sex. Diagnosis requires a sleep study. Treatment for OSA is primarily CPAP, continuous positive airway pressure.
Moving to sexual and gender disorders, what is the defining feature of paraphilic disorders?
They involve preoccupation with or engagement in unusual sexual fantasies or behaviors for at least 6 months, causing significant distress or impairment. They require intensive psychotherapy and behavioral therapy and potentially anti-androgens for severe cases.
And gender dysphoria.
This is a significant incongruence between assigned gender at birth and current identity, lasting at least 6 months. It is highly associated with depression and anxiety, which must be addressed first. Treatment, if desired, involves gender-affirming surgery or hormonal treatment.
We must cover sexual and physical abuse and assault. In a clinical setting, what are the red flags for abuse?
Victims often present with multiple somatic complaints, delayed emergency treatment, or unexplained injuries. Clinicians must screen for close personal relationship abuse.
And in sexual assault cases?
In sexual assault cases, the assessment is extensive. Physical and psychological evaluation, pregnancy testing, and full comprehensive testing for STIs like chlamydia, gonorrhea, HIV, and hepatitis.
The crucial element here is post-exposure prophylaxis, PEP.
Yes. Follow-up medical visits are standard. Antibiotics are given for common STIs. The most critical intervention is offering HIV post-exposure prophylaxis, or PP, within 72 hours of the assault. Emergency contraception must also be offered.
We end with suicidality, the 10th overall cause of death in the U.S.
Peak rates are seen in adults 45 to 64. It's important to note, females are more likely to attempt suicide, but males are statistically more likely to complete suicide, often using more lethal methods.
The risk factors are summarized by the sad person's mnemonic.
That's right. S is for sex, male. A is for age, older, though 18-25 is also high risk. D is for depression. P is for previous attempt, which is the single greatest risk factor.
Okay.
E is for ethanol substance abuse. R is for rational thinking loss. S is for sickness, chronic illness. O is for an organized plan or access to means. And N is for no social support.
What is the treatment mandate here?
The treatment mandate is non-negotiable. Emergent inpatient hospitalization is required for any patient endorsing suicidality, even against their will.
And the final warning about young adults and antidepressants.
Antidepressant therapy carries a black box, warning that it may temporarily increase the risk of suicide in patients younger than 24 years of age. This requires careful monitoring upon initiation. That was an immersion into the complex structure of clinical psychiatry. We moved with precision through the entire developmental timeline, mapping out how crucial the duration criteria are, from 1 day for a brief psychotic disorder up to 6 months for GAD or 1 year for conduct disorder.
Absolutely.
We defined the difference between acute delirium and chronic dementia, and we charted the entire spectrum of pharmacological risk.
What resonates for me is the dual necessity of having both the strict chronological rules and the nuanced understanding of drug mechanisms. We saw the time-sensitive nature of EPS, the immediate dystonia, the weeks-long akathisia, and the high stakes of narrow therapeutic windows for medications like lithium. This level of detail provides you with the foundational framework used in clinical settings, the how and the when of psychiatric care. We also spent significant time on the list of defense mechanisms, from the immature ones like splitting and projection, to the mature adaptive forms like sublimation and humor.
My final thought for you is this. Consider how deeply these defense mechanisms regulate conflict and stress. If you recognize projection, the blaming of an external source for an internal impulse, what does that tell you about the speaker's emotional state? The ability to see past the content of the argument and identify the psychological structure of the defense is one of the most powerful insights this material offers. Use this knowledge to understand not just clinical behavior, but perhaps to better analyze and manage your own automatic protective responses to stress in the world around you.